In our mission to alleviate the suffering of underprivileged children with heart conditions in Uganda, the Keith Heart Foundation embarked on a campaign to search for those acute cases that require urgent and timely attention. The Keith Heart Foundation caught up with Dr. Sulaiman Lubega of Uganda Heart Institute in Mulago Hospital, alongside the family of 1.5-year-old Elisa Mwanzi, who at 8 months old was diagnosed with a ventricular septal defect and an atrial defect. In layman's terms, baby Elisa has 2 large holes in his heart and requires urgent surgery.
So in this view, you see this wall should be reaching up. This one stopping here. Should be reaching up. And now there's a hole there. And that's why you see this color. That is the blood crossing that hole. So he has 2 big holes in the heart, which would need attention. This is what we call a ventricular septal defect. This one. This is the left ventricle. Then left ventricle, right ventricle. And the other one I'll just show you. Just show you the other one. It's called the PDA. Hey. The other one is this one. Because it's moving. This one here. Up. That one should not be there. I can put in color, then we'll see blood crossing there. That red blood.
Yeah.
That is called PDA. So that is also not supposed to be there. So those are the holes here. He has a big VSD and a large PDA. Okay. This is the hole. Suppose he's moving, children will not be still. The hole. That color you see. My name is Dr. Lubega Sulaiman, consultant pediatrician, cardiologist, working at Uganda Heart Institute. I've been in touch with this patient here. We are seeing Mwanzi Elisa, whom I've been privileged to handle since the last 2 months. However, the child was born with a heart problem, and the heart problem came to our attention when they presented with a history of difficulty in breathing and poor weight gain. At that time, they were referred from their peripheral health unit to this institute because they had suspected a heart disease. When the child came here, that's about 2 months ago, we were able to carry out investigations, and we did an echo, which is an ultrasound for the heart, and found out that the child had 2 big holes. One hole in the heart that is called a ventricular septal defect, and another hole, a big one, joining the vessels, the big vessels as they leave the heart. That is called a patent ductus arteriosus. These big holes had caused the heart to enlarge because they are causing a lot of blood flow within the heart, so the heart had enlarged, and as a result of that, the child was in heart failure. Clinically, even when we saw that child at that time, the child had fast breathing and chest deformity as a result of that difficulty breathing that had been there for a long time. So we started the child on some drugs, which are anti-failure drugs. We started the child on tablets, Lasix, and captopril, for which the child is still taking up to now. However, given the size of the defects, we expect this child to have operation to prevent complications. Because as we know that large holes in the heart, the large VSD and large PDA, will eventually lead to pulmonary hypertension, which is a complication. So in order to circumvent that problem, we need to operate this child. The earlier we do the operation, the better for the child, because this is a child who has so many years ahead of him. So we need to carry out operation. At the moment, some limited operations are being done in Uganda by our local surgeons. However, some operations are not yet done at the moment, and we usually handle children who are above 10 kilos. At the moment, as we speak today, this child is about 7.5 kilos, and yet we would expect this child to be about 11 kilos, meaning that the child is failing to gain weight appropriately as a result of these holes. So we need to look for avenues to operate this child. We've been trying here and there. We've tried to apply to India, where they suggested a cost of about $10,000 for the treatment alone, excluding the transport fares and upkeep for the family while in India. However, as the family, as you see them, they are not able to afford this. They are peasant. The father is a peasant farmer, and the mother is a full-time housewife. They don't have money to fund that operation, and as a result, they've not had operation to date. So we are still looking around for possible donors who will help us fund this operation. And as we were looking around, we came in touch with part of the Keith Foundation, and we had an intention of funding some children with heart disease in particular. So I did get in touch with this family, having known them for some time and knowing their economic background, which is so poor. I thought they were a suitable group to help in case we need to fund any children. We do have many such children who need operations and cannot afford the cost of the treatment. We actually at the moment have about 2,000 who are pending and need operation, heart surgeries, and that's also a tip of the iceberg, as many are out there and we've never had chance to diagnose them. Those who are lucky to come here, the ones we are really talking about. So we really have a pool of about 2,000 patients with heart disease needing operation. And whenever we get a chance, we keep operating on some. We do get groups from outside, Uganda, from America, UK, this Chain of Hope, which helps us from UK. And we get some groups from sometimes Korea, and many other donors who help us through the Rotary groups. So this child has not had a chance to date for the operation, and we hope that probably through the Keith Foundation we may get an opening to be able to operate on this child. This operation, as I've told you, that the child has large holes in the heart and the other hole outside the heart. They are all large holes which need urgent attention. At the earliest possible opportunity, we need to get this child operated to prevent the unwanted complication of pulmonary hypertension. That means that whenever we get the funds, we should have operated this child yesterday, but the funds were not available. So the earlier the better, in order to prevent this child getting into problems, because we know that most of the growth of the children occurs in the first 3 years. Anything that affects the child significantly in the first 3 years of life will have a far-reaching impact on the growth of the child. So this child's growth has already been affected as a result of the large hole, but we need to stop that by having the child operate. And definitely children of this nature, children who have holes in the heart and have an increased blood flow to the lungs, are already predisposed to respiratory tract infections, even without any other risks of infection. So in our environment, where we have a polluted environment, we have a lot of infections in the community, and in addition to that, we have a hole in the heart, large holes. This child is exposed to a double tragedy. He's more predisposed to respiratory tract infections, and indeed we've managed this child for respiratory tract infections before, and will continue to manage them. And these repeated infections do affect the child, in addition to the heart failure that the child has to live with.
What about after operation?
Yeah, after operation, luckily enough, these operations that the child needs a closure of the VSD, and for that they usually do a patch closure. They put some patch, and then the PDA, which is large, that one is usually irrigated. After operation, the child will be cured of those defects. Apart from very, very few side effects which may come in, but having been operated, this child will be able to live in the community like any other child who has not had a heart disease before. So the prognosis of the child post-operatively is good, and here at Uganda Heart Institute, we are able to provide the necessary follow-up treatment should the child be able to get operated elsewhere. We are able to take care of the child's condition post-operatively, and the future follow-up also very, very much possible here in our institute. This is an operation which usually will take about 3 hours in the operation theatre. However, usually there are many, many stages to get to that. So sometimes the patient needs to take a long time between leaving the father to go to the theatre and coming back. But the operation itself will usually be about 3 hours. The prognosis is really excellent for this child. When they operate early on, when they're children, it's much better than when the operation is delayed. In the meantime, before the operation can be, or placement for operation can be got, we are managing this child for the heart failure using drugs, and we're using 2 drugs as of now. We're using Lasix and Captopril, and we've advised the family about a good nutrition in order for this child to put on weight, because we know that most operations, the success of the operation also depends on the patient's weight. Currently, the child is weighing about 7.5 kilos, and preferably we would have wished this child to be about 10 kilos. However, at any age, the child can still be operated if the situation warrants so. So we advise the parents about the nutrition, but given their financial capacity, that has been a challenge to get them appropriate, because the child would have needed a lot of proteins, a high protein energy diet. But the financial situation of the family is a constraint. But yes, nutrition is very important, and it's one of those things that we advise the family. So we have, in the course of managing this child, I've been able to get in touch with the family and discussed the management options. I've informed them time and again that the medicines are not a cure of the patient's, of the child's ailments, but surgery will be needed at the earliest opportunity. The family is agreeable about that option, the surgical option, and they're waiting for that chance when the surgery or any well-wisher may provide the funds for the surgery. So they'll be very, very willing, and they will embrace the surgical option should it come by. At the moment, we are able to do limited operation with our surgical teams. And at the moment, we do most of the closed heart surgeries. But when it comes to the open heart surgeries, we've been mainly dealing with atrial septal defects. Those are the defects in the heart which are above, in the upper chambers. This child has a defect in the lower chamber. He has a large inlet VSD. And as of now, the local team is not comfortable to handle these sort of defects, and we've been mainly referring them abroad. And occasionally when we get visitors or visiting teams coming to Uganda, we do handle children of this nature with the visiting surgeons who have come from abroad. But our local team is currently not comfortable to handle this child as of now, and we have to get placement outside Uganda. We have a very large pool of such children. However, when I discussed with the Asha, we decided to begin with one, and it will be the success of the one that will determine the future plans. So that means the patients are really so many. Every day here, we screen about maybe 10 to 15 patients for heart disease every day. And 5 of those every day will have significant heart disease that requires operation every day. So I can multiply that, and it's really to this particular child, the cause is still But although the cause is not clear, at least the treatment is very, very clear, and it is curative. Than children, so you guys so far. Child was operated, had a Glen shunt, which was done at the end of last year, and now gets fluid collection in the chest, right-sided chest, and that is chylothorax. So was readmitted this time for what we've been doing, tapping the pleural space to remove the chyle, that is the chyle from the chest. And the child is now stable and will be discharged probably sooner than later. It's palliative.
How long will you keep doing that?
And now they put in some drug to try to close off the space, rhodesis. And so that's what they did. They put in twice now. Put in twice. Bleomycin. Okay. So they put in tetracycline. Yeah, they used tetracycline or bleomycin. But they are saying bleomycin wasn't seen, so they put in tetracycline. So this one has tricuspid atresia. That's the problem here. The tricuspid valve.
You're going to manage fully without
We did a palliative surgery, a Glen. So this is a tricuspid atresia. After Glen, they did a Glen procedure. About 12. An acquired heart disease, rheumatic heart disease with severe mitral regurgitation, and has severe pulmonary hypertension. We are currently managing him for intractable heart failure, and that's why he's here. He came in all swollen up with difficulty in breathing, his fatigue and palpitations. He has been started on IV Lasix and he's improving as of now. We have disturbance, he has hyponatremia, but we're dealing with that. And he's improving. He also needs valve surgery, actually. He needed it some years ago.
Oh, but the fans,
but the fans, so it's usually a funding problem that leads us into complications. The patients come to this. So this side is the general one.
Oh, there's a baby.
One of the other children, the child we're dealing with has a PDA and a VST. This child had only a PDA, which was ligated yesterday, and is now just being monitored for recovery. He's doing well. Where is this statement?
The Keith Heart Foundation team bids farewell to Dr. Lubega and embarks on a long journey to the Muwazi family home.
Nze Moses Muwazi.
Moses?
Muwazi.
Ate mukadde?
Nze Geetu Batamuliza.
Okay, ate omwana?
Omwana Elisa Muwazi.
Okay. Kati
nendabanga Ssakumukumu. Bwe nalaba Ssakumukumu ne mutwala ku musawo w'okukyalo, kuno kuliko omusawo.
Myezi mekeji.
8 saamulabirawo. Nabeeranga ngamba abaana abawerevu baleka bwe basajja kutereera. Naye nagenda okulaba okussa kususse. Ne mutwala ku musawo w'okukyalo. Omusawo w'okukyalo n'amupima, waliwo akapima n'agamba emirundi gy'assa si gyetaagisiza okussa. Nangamba agenda ku ddwaliro lya gavumenti liri eri Bukasa. Nengendawo bwe natuuka wali ne bansindika e Wakiso. Bwe natuuka e Wakiso ne bansindika e Mulago. Ebyo ne baŋŋamba mutwale bamukebere omutima n'amawuggwe. Basooka ku mawuggwe ne bagamala, ne ŋŋenda ku mutima nagwo ne bagumala, ne baŋŋamba kuliko ebituli bibiri.
Kati gwakitwala otya bwe wamanya omwana wo alina ebituli bibiri ku mutima? Mwakitwala mutya? Kyabayisa kitya?
Kyatuyisa bubi. Nenkomawo nentandika okusaba kuba ndi mulokole. Nenzikiriza Katonda omuwonye olw'ensonga tinali sirina ssente. Kati yampa eddagala lya myezi 6. Ensonga luli lwakwatibwangako ekifuba ng'abeera bubi nnyo. Kati bwe yabeera kye kyatuwalizisa okugamba nti bali abaana abalala bulijjo si bwe babeere bakwatibwa ekifuba, oyenga ebbombo n'ebiki n'evvu n'omuwa n'atereera. Naye ono ye nga tatereera. Naye kati okuva lwe batandika okumuwa eddagala tekikyamuyisa bubi, kimuluma n'asigalawo awo. Naye ng'era baŋŋamba olumukwata mugulire amokusiiru. Era olumukwata ng'enda eri e Bukasa nga mugulire naye nga takyayisibwa bubi. Nze mbeera mukutte. Mbeera waka nga mukutte, baŋŋamba takaaba. Kati n'omusana bw'omuteekeyo oba n'ogezaako n'ogenda n'olima naye nga takula nnyo omutwe. Kati nga simuteeka nnyo musana, sibeerayo kati nga gwase bwe guti, sibeerayo. Mba nina okuba nti ndi waka, abeera mu kisiikirize.
Kati buno obulwadde bwa mutima waliwo omulala abulina mu famire yammwe? Mulina obulwadde obulala bubatawaanya mu famire yammwe?
Obulwadde obututawaanya era buba musujja lubuto. Kati waliwo awo okuva myaka 9 lubuto lumuluma.
Ne Elsa alina baganda be bameka?
Elsa alina baganda be 6. Neetaaga okuyambibwa. Kwe kubeera nti kati sigenda mu nnimiro nga bwe ŋŋende ng'egyateetaaga musana. Mba neetaaga nga ndi waka nga nkolera waka emirimu gyange. Kuba nayagala dda okwongera ku nnyumba eyo ntandika okutundira ebintu ewaka. Nga bw'olabye eno kati ku kitundu kuno kuliko obuduuka obwo bubiri. Kati nze nange bwe nteekawo eryange mba nkola. Nembeera ewaka n'omwami ono engeri gye baŋŋamba talina kkaaba. Era nsijja kulima nti nze nkola. Olina okubeera ng'omusitudde.
Kati agenda naye mu ndimiro?
Ngenda naye musibako ku mugongo. Kati ate engeri oba gy'alina ekizibu bw'okutama tayagala. Era ng'odda kati oba olaba nti ebiseera ebisinga kasa yeewunzikamu ate teyeebaka nnyo, yeebakako katono. Kasa yeewunzikamu bw'oba wagenda oba osima emmere ng'olwogireeta mangu. Ate olumu era osima ng'era bw'odda olabe kuba talina kkaaba. Talina
emyaka emeka?
Nsooka alina 15.
Muwala?
Mulenzi.
Basoma bo?
Babadde basoma naye olw'ebizibu ebiriwo sente eriwo zaagaana. Tuva eno netudda eno okugenda olulujja ssente teekateeka siyaye tebadde yakugamba nti kati nga bino byebimuli boogera bigwa bitalaze kati bye bino mu maka gaffe teekateeka ebeera ndala ate ne wayingirawo endala. Nina n'engeri endala nga naddala okujjanjabibwa okulaba obulungi nti paka lwe tunasuuka. Ekyo kintu kikulu nnyo gye tuli kuba tetulina busobozi busobola kwetaasa. Olumu bwatugamba nti ojja kuleetayo obukadde 2 tuyinza okuba nti bukuŋŋaanyizibwa okumala emyaka 3. Kuba lwa nsonga bw'obeera nazo wadde obulina 2 omwana taasome mulala tayambale
kati enva mukola mutya
enva ebiseera ebisinga by'olumonde tulya mukalu tuteekako ebbinika y'amazzi netunywerako
enva zikutawanya nnyo
enva zintawanya nnyo ndya nnyo emmere enkalu nga bw'okiwulira
n'abaana bonna
ne banywa cyayi omukalu